All right, good morning, everyone, and welcome to another installation of NB Heart Center's CV Weekly Rounds. This morning, I'd like to introduce one of our interventional cardiologists, Dr. Jaroslav Hubacek. Dr. Hubacek has been with us now for almost 8 or 9 years and has been a great addition to our program in terms of really advancing interventional cardiology techniques, percutaneous techniques, as it relates to coronary disease and otherwise. And he's kindly agreed to give us a 3-part series lecture on things related to the cath lab, and more specifically, questions that a lot of us have as it relates to coronary angiography. And the first talk is looking at diagnostic modalities in the cath lab above and beyond the gold standard. So many of us we'll look at reports and see iFRs, FFRs, RFRs, and various other interpretations of lesion significance that are more than just simply a percentage. And it's not always clear as to what it is that they imply or mean. They often will indicate what they mean in a little notification. But I think at the end of the day, having somebody come and give us a little primer on all of this is extremely important. So this is the first of 3 lectures over the course of the next couple of months that Yara will be giving to us. So thank you so much for agreeing to do this. I'm sure this will be incredibly instructive, and looking forward to your talk.
Thank you, Ansar. Ansar approached me a few months back about talking about above and beyond the angiogram. So for majority people to the cath lab, and they immediately assume patients will get stent, and that's actually not what we're doing in a cath lab. We're starting with coronary angiogram, or looking at the coronary artery, hemodynamic assessment, right and left heart catheterization, identifying structural problems, doing the aortogram. So we do many things outside of pure coronary artery disease, which those is bread and butter of what we do. This talk will focus on coronary disease and coronary angiogram, which so far is the best to triage patient between going for medical therapy, doing the PCI, or going forward for bypass surgery based on their anatomy. Just to demonstrate how complex the problem is, we're trying to do 3-dimensional object that it's constantly moving by 2-dimensional modality, which is the X-ray. So if you imagine trying to image this, it's rather challenging and therefore require multiple views. We have 2 major planes, which is intraventricular plane and atrioventricular plane, which essentially are perpendicular axes, which give us the best view of the coronaries and subsequent lesions. This, for those who don't see the coronary angiogram all the time, this is what we see. On the left side, there is RAO view of the left coronary artery. And on the right side is LAO caudal view of the exactly same artery, which looks so much different. So we're using multiple projections and the views in coronary angiogram to delineate each part of the vessel, which the best visualize the segment and so-called open the stenosis and identify the worst possible view. Angiogram is a gold standard since 1958 and is the perfect tool as demonstrated on this picture. Just because you're seeing in one view doesn't mean that what you're seeing is true. Despite the fact that it's quote-unquote gold standard, there's multiple limitations I'm trying to outline in here, starting from patient body habitus, fact that there is no optimal angiographic review because each patient is a different, fact that we need to make a decision right away to make a diagnosis, and any specific measurements that we're using routinely, and we're using visual estimate, so we eyeball the lesion. This is a typical example that we see in a cath lab. Again, another case from the textbook, and you see 3 different views of the same left coronary artery, which in pain on picture A, you don't see any lesion. In picture B, you see the LAD going down the screen and then diagonal, which has some lesion. And then on C, you might see that diagonal is not that bad, but worse. And if you look at the same picture 3 times, you get interpersonal variability. Every other day you will see something different. If you ask second opinion, they will see something different. Again, pointing on the fact that coronary angiogram is very subjective. Why is it subjective? I'll try to walk you through the reason why we all see different things. And the best example is using eccentric lesion. So on the left-hand side in the cartoon, you have vessel with 50% stenosis, and long axis of the lesion is parallel with the x-rays. And then on a screen, you will see 50% stenosis, little bump across the vessel that you identify as a stenosis. If you rotate the exactly same vessel, exactly same lesion, 90 degrees, and now the vessel is long axis of the lesion is perpendicular to the X-ray, you will see nothing, i.e. there is no lesion based on your angiographic assessment. Put it in a perspective, I borrow from Dr. Costa this animated example. In the middle, you have the artery, which is normal lumen. You have X-ray source that go through the artery, and you have the image when you fill vessel with the contrast. If you make the lesion 50% or 70%, but you make the long axis perpendicular to the X-ray, you will not see any change in a lesion. Now I'll slowly rotate the artery, and you see that the image of the blockage significantly changes. I walked through it a few times. Therefore, when we're doing the angiogram, the goal is to identify the view that makes lesion looks the worst, because most likely we have the most true representation of the lesion. That said, our eyes are lying to us all the time. If you look at this picture, the question is which line is straight? And your eyes would tell you that it's essentially lines just on the outside. But when you make straight line, all those lines are straight, just those little small squares make it look that it's not straight. So this is in a cath lab on angiogram for shortening of the vessel. So the vessel not only has to be positioned proper way towards the long short axis of the lesion towards the X-ray, it has to be quote unquote open, i.e. not foreshortened and demonstrating all alike. The next one is when you have 2 different objects and comparing their size. If you look at picture on the left, the orange ball looks significantly bigger than one on the right side, but as a matter of fact, is exactly the same thing. Again, eyes are lying to us based what's around the object that we're trying to focus. So if the angiogram is so bad, as I just demonstrated, it has so many flaws, do we have anything better to do? On the bottom, there is CT angio, which is 3D reconstruction of CT scan and has its own flaws. We were hoping it will decrease amount of the diagnostic coronary angiograms we have to do. Unfortunately, opposite is the case, and we're doing more and more because of the CT scan. Then we have a stress test, which has its own flaws, but everybody should have a stress test before they even come to the cath lab. Then leave us to the invasive testing in a cath lab, which we have intracoronary imaging, either IVUS or OCT, and then physiological assessment of the lesion, FFR and iFR. Most important part is to understand that anatomy drives the physiology. Abnormal function then leads to pathophysiology, which leads to the state, disease state, and subsequent dictate what we should be doing. Understanding this time change and spatial resolution of the disease, normal and abnormal, is extremely crucial. So it's not just one frame that we're seeing, it's the evolution over the time and subsequent consequences for the patient and affecting the treatment. So let's look at what do we have in a cath lab above and beyond coronary angiogram. We have intracoronary imaging, so i.e. looking at anatomy from inside of the vessel, and physiological assessment. I'll start with the anatomy, since angiogram is anatomy. We have, out of 4 that are listed, we have 2: intravascular ultrasound and optical coherence tomography. These are the major differences. IVUS is the old technique with relatively small resolution. OCT is new technique using the near infrared light, which has high resolution. Comparison, it's driving on a sunny day, i.e. OCT, driving in a snowstorm is the IVUS. Very significant change in ability to pick up of the things. Disadvantage with the OCT is you need to use the contrast and you need to clear vessel lumen of the blood. So there cannot be blood, otherwise you have similar problems with the IVUS, you don't see anything. What are the advantages one over other? IVUS, because this data is really good for left main diagnosis and decision-making process for treating vessels going forward. Both are really good for assessment of the calcium, and OCT is really good for final details, i.e. stent expansion apposition. Furthermore, OCT has really good tissue differentiation, defining plaque characteristic, identifying dissection, thrombus, differentiating even between red and white thrombus that helps us with diagnosis. However, those are above and beyond the scope of the study. So let's look at the IVUS and the left main as the first part. Literature study demonstrated that if we're using the IVUS and we're using the cutoff point of MLA, minimum lumen area of 6 millimeters square as measured, i.e. what is the lumen of the left main, if we proceed and randomize treat patient with MLA less than 6 millimeters with the revascularization, and those more than 6 with a medical therapy or deferred treatment, their outcome up to 800 days, as in a literature trial, was the same. If you look at the cardiac death was the same. However, when we look at a small subgroup, and again, this is the problem with all the literature trial and all the intracoronary imaging trials have relatively small numbers. If they look at the patients that have MLA more than 6 and they're on a medical therapy versus those that have MLA less than 6 millimeters square, there was statistically significant difference in a cardiac death. This is the evidence that we're using to identify patients with the angiographically borderline left main to decide whether they would benefit from revascularization or whether they are better served with the continued medical therapy. Next part was identifying the calcium. The IVUS is very easy to spot the calcium because it's that wide rim in a vessel. And it's significant calcium if it's napkin ring or 360, or significant calcium if it's more than 260. Unfortunately, IVUS provides significant calcium provides significant shadowing to the IVUS. Therefore, we don't see much beyond the calcified segment, so we can't assess its thickness. Furthermore, there's a pullback on the vessel, which give us better view in OCT, where you can identify thickness of the calcium, circumference, and the length, and help you to differentiate which vessel will be more likely amenable to the angioplasty. These are just the different examples of normally deployed stent in a coronary artery by OCT and IVUS. Malapose stent means the stent doesn't reach the vessel wall. These are the stent strut, it doesn't reach. Same in an IVUS setting. And then you have underexpanded stent, mean that stent in the reference is well opposed and has an area of 6.2, and OCT is only 3.2, i.e. is significantly smaller, and a similar picture in an IVUS. This is the summary slide where we're looking at stent result, looking for the malapposition, underexpansion, dissection, minimal stent area, and percentage of the underexpansion that should be less than 20%, or reference if the stent should be more than 80% of the proximal reference. Does it make any difference in the daily practice? Based on the IVUS XPL trial, A patient that had angiographic guided PCI had mortality about 6%. If the IVUS was used and for the guidance of the PCI, mortality went down to close to 3%. And furthermore, if you look at a patient that had used the IVUS and met the criteria of successful PCI, which we just discussed, then had again significantly reduced primary endpoint. So IVUS led to significantly improved outcome in PCI patient. AHA recommendations saying that we should use 2A and 2B recommendation for the angioplasty and diagnostic imaging. So let's move from anatomy and abnormal anatomy that determines physiology, the actual physiological assessment, which there are 4 different measures. 3, iFR, FFR, and RFR are pressure derived, and CFR, which is coronary flow reserve, which is flow derived measure. Important to understand why physiology is more important. Diameter decreasing throughout the coronary trees, cross-sectional area is decreasing, resistance is increasing, and flow is decreasing throughout the coronary tree. However, pressure remains the same. This is very complex calculation of what you consider in FFR, which is pressure above and beyond the lesion, microvascular circulation above myocardial supplied, and RA pressure. For simplicity, for simple mind like me, it's mean PA distal pressure versus mean A pressure. Important thing to remember that using Bernoulli equation, that pressure drop across the stenosis is not driven only by the lumen across stenosis that we're normally using, by the flow, means how much blood going through, and the lesion length, which help us to determine the outcome, the severity of the lesion. Is there optimal threshold? Optimal threshold is the one that intervening on the vessel above that threshold making patient worse, intervening below that threshold actually making patient better. We have for FFR the ischemic threshold when the lesion causing ischemia is 0.75. Clinical outcome based on FAME trials if it's less than 0.8. And critical, if it's less than 0.66, we're barely doing those because those are 90-95% lesion. On the little squares in here, you see as the pre-flow significantly reduced because of the stenosis based on the FFR. If you intervene on that, lesion flow improves. So further away you are from 0.75, 0.8, the more benefit patient gaining. There are multiple trials that were done. Differ, FAME2 and FAME3, essentially delineating the points, i.e. 0.75 for ischemia and 0.8 for clinical significance. FFR has the problem, therefore iFR was developed to try to avoid need for hyperemia, use adenosine, assessing tandem lesions, and avoiding effect of LVDP and high coronary flow. It measures diastolic pressure, 25% from the onset to 5 milliseconds to the end of diastole. This picture is remarkably similar to the previous one. Ischemic threshold is 0.85 instead of 0.75, and clinically significant is 0.89. For those who can't remember the difference between 0.89 and 0.80, it's 0.8 or 0.9 for simplicity. iFR and FFR measuring the same thing. It's like a comparison Celsius and Fahrenheit, measuring the same thing, just the number is different. 0.9 for iFR and 0.8 for FFR. There's no difference between iFR and FFR versus clinical results as defined by defined flare and sweetheart. Huge advantages assessing tandem lesion because on a pullback you have instantaneous pressure drop, which you want to see the rapid sharp change in the pressure, which delineate that the lesion is significant. What you don't want to see is this slow gradual onset, which demonstrate that the lesions are coronary artery disease is diffuse and there is no particular one spot where you can intervene on to relieve pressure gradient, i.e. ischemia. What's coming is simplified version. When after you do the pullback, it gives you dots for any drop of the blood pressure across that lesion. And then you can just choose which vessel which lesion you're going to treat, and it gives you the final iFR based on how many lesions you will intervene on to be sure that final result is results of all the trials left the recommendation by AHA-ACC of class 1 and class 2A for assessing hemodynamic significance of borderline lesion and for guidance of the PCI. So in summary, despite the coronary angiogram is gold standard, and so far the best tool we have to triage the patients, it has its limitation and risk. Using invasive physiology, FFR, iFR, RFR, and intracoronary imaging is attempt to try to get subjective out of the equation, so trying to avoid oculostenotic reflex. It was proven to reduce the need for PCI on intermediate lesions and hurting patients, and improve our PCI results by optimizing it using both iFR, FFR, and intracoronary imaging specifically. Thank you.
Thank you very much, Yaro. So just a quick question from me, and then I'll open it up to the audience. And please feel free to use the chat box or unmute yourself. The question I have is, when do you choose to do an iFR or an RFR versus an FFR? I almost need you to go back to that slide where you kind of describe, the PD versus the PA, and kind of just maybe describe a little bit how it is that you actually do it, and then indicate when it is that you sort of move towards one technique versus the other.
So there are several reasons why we choose one over other. Number one is the technical one. iFR wire is really bad wire to get it in the places where you want to. So if the anatomy is complex, advancing iFR wire to distal LAD, if you can't advance in there, you can't measure. Therefore, you won't use iFR. St. Jude wire that measures FFR and RFR is a way better wire. Therefore, it's easier to advance where you need to. There are other techniques why don't go there, how we can do it. But in a principle, FFR is old system, but requires hyperemia. If don't achieve maximal hyperemia, you don't get good result. It's affected furthermore by the tandem lesion. If you have multiple lesions and you want to specifically say, is it left main or is it mid LAD that's causing the trouble? FFR will only tell you the two. iFR has ability to differentiate which lesion causing which problem and does not need adenosine. Is less dependent on LVDP. If LVDP is high, FFR will be falsely negative. And high coronary flow, there's a so-called discrepancy between iFR and FFR. So often when we're trying to approach the surgical revascularization for patients, i.e. assessing LAD, left main lesion, trying to do both if technically feasible. iFR and FFR having the data, RFR is just extrapolation of the data, so it doesn't really have true evidence-based medicine behind it.
So I guess that brings me to the next question is, this is from Dr. White, are there any options for assessing borderline lesions in patients with severe aortic stenosis? So maybe just explain why it is that the severe aortic stenosis is a potential confounder and what alternate techniques you might have for these patients.
So there are aortic stenosis causing significant trouble because of the microvascular bed and underlying LVH, and often elevated LVDP. Ability to achieve maximal hyperemia with FFR is significantly reduced. And there are, because FFR is so dependent on a macrovascular bed, there's often a poor correlation between FFR and subsequent severity of the lesion. iFR seems to be less biased towards it because during the diastole, there's minimal resistance, which is constant during the diastole, and therefore is inherently less affected by severe aortic stenosis. So if we want to assess severity of lesion, it should be iFR. Data are not in double-blind randomized trial pre and post AVR. They are just clinical observation and observational data rather than randomized trial. Therefore, if you have borderline lesion, especially if we're talking about the left main, probably using the IVUS might be better because we have a data. If you are in a proximal bed and you don't believe hemodynamics, then using imaging again would be a better idea.
Next question is, so just overall, what do you think the barriers are to the increased use of functional testing? There's times when, for instance, we'll see a patient with a borderline lesion, but nothing's been done, versus other times when clearly, you know, the interventionalist has taken the time to do the, you know, the additional diagnostic modalities. So what are the barriers? Is it a time thing? Is it a cost thing? Is it a practitioner preference thing? Is it a technical ability thing?
It's driven by intra and intrapersonal variability of assessing the lesions, i.e. what I see and the surgeon see are not always the same thing. So always keeping in mind who am I passing the information to and why. It's very important. So more discussion about doing either imaging or hemodynamic assessment is if it's truly borderline lesion that we can go forward. Other barriers, penetration everywhere in the world is about 10% for all cases being done, with exception, I believe, South Korea, which have absolute like 100% use for all patients, but the price for them is significantly lower. Just to put in a perspective, using FFR, OCT, IVUS is $1,000 extra for every single patient we would be using it. 4,000 cases, so you can imagine what the price would be. That said, if we select the patients and trying to use it very selectively, we're doing a pretty good job. Often for our own practice, in our own institution, when we have disagreement between is it severe, is it not severe, we're leaning towards providing another information. Unfortunately, many people do not accept the result, so then patient has subsequent tests such as stress test, stress echo, stress maybe, and trying to figure out whether that result is correct.
Yeah, no, thanks. I agree. And I think, you know, obviously it is very user dependent, both at the end user level and at the at the upstream, you know, interventionalist level. Is there, I mean, we discussed this at Journal Club a couple of iterations ago, but is there data to suggest that at least in the coronary bypass grafting world that, you know, FFR or iFR guided bypass surgery is as effective in terms of determining long-term graft patency versus just simply leaving it, you know, to what your angiographic interpretation is?
So there are several trials, and we discuss it as you indicated. It appears that for arterial graft, FFR is very good in predictability which arterial graft will stay open, whether it's lima, rima, or radial artery. For the vein graft, the results are less striking and correlation is not that clear. Hypothesis behind it that patency of the vein graft is not directly driven only by the severity lesion, by the quality of the vein sustained and being exposed to the arterial pressure, i.e. it goes down not because there was no lesion, it goes down because the poor quality of the vein was poor compared to using arterial graft.
And last question before we sign out, a little bit different, but still a good question. When you determine finally that a lesion is significant, what prompts you to use a drug-eluting balloon versus just a simple regular balloon angioplasty?
So in 2020, we very rarely using plain on balloon angioplasty or drug-eluting balloon by themselves. We're using them only in restenosis lesion. If we identify that the instant restenosis is driven by the mechanical problems, i.e. something wrong with the stent, then POBA, plain old balloon angioplasty, should be sufficient because you get rid of the reason why the stent restenosed. If you have no mechanical problem and stent was perfectly deployed, or as perfectly as it can be, and restenosis occur because of superimposed intimal hyperplasia, then deploying drug-eluting balloon might be a better way than putting another layer of the stent, which now we have 2 layers of stent, and then significantly increasing another instant restenosis.
That's great. Yara, thanks so much. We appreciate this. I mean, it's obviously don't be upset if I ask you a very basic question yet again when we next see a consult together, but nevertheless, very much appreciated. Thank you for giving us this primer. And we will see you in another month or so for how to deal with calcified lesions in the cath lab. So thank you once again.
Thank you, and thank you everybody for listening.